My name is Raymond Kwong. I'm the Director of Cardiac Magnetic Resonance Imaging of the Brigham and Women's Hospital. I'm here to present to you the current clinical applications of cardiac MRI as part of this review course. So first of all, I have no relationship to disclose that is relevant to this talk. The use of gadolinium contrast agent is still considered off-label in cardiac MRI imaging. So let's start out discussing some of the rationale for using cardiac MRI. Then I will also briefly touch on the advantages and disadvantages of cardiac MRI. Then I plan to show some clinical cases to illustrate the utility of this technique in day in and day out cardiac patient management, and we'll finish with a list of the contraindications that we have to be concerned about before we order a cardiac MRI. So first off, why we need cardiac MRI? What are the strengths? Well, compared to other techniques, one of the strengths of cardiac MRI is that you can get to any cardiac structure, any major cardiac structures in arbitrary scan planes. So you can cut the heart in any angle that you prescribe to get to a structure of interest. A key strength of cardiac MRI is the fact that with or without contrast usage, cardiac MRI can discern the different types of tissues in the heart and surrounding structures, and be able to tell normal or pathologic states. You can also tell, for example, fat versus myocardium, and within the myocardium whether it is accumulating contrast or not. There are also non-contrast technique that is already fairly proven to be fairly useful in determining pathologic conditions of the heart, and you will see examples of these. MRI has also a combination of high spatial and temporal resolution. In terms of spatial resolution, it is not the highest. For example, CT and echo has higher spatial resolution. And in terms of temporal resolution, MRI is actually inferior to echocardiography. But in combination with the 3 points above, it does allow MRI to be a unique method to assess cardiac structures and anatomy. Another thing that MRI that is a strength in cardiac MRI is that there are many pulse sequences, or so-called, or what these are the software of the MRI method that is constantly being updated or invented that allow the technology to move forward in uniquely assessing the heart in different ways. So it's a software technique as opposed to just advancing by hardware. As I mentioned, that MRI can assess cardiac structure and physiology in a single examination session. And also, MRI, of course, does not require the use of ionizing radiation. So MRI many of us will think of it as the imaging of water, because our body is made up of water in 80% of its components. So the water in cells or in any structures get activated by MRI. But in fact, it is not really the water. It is actually the proton that is attached to any molecular structures in the body. So when the proton is attached to water, it gives off a specific frequency, and it's specific to a body tissue. Tissue type, such as myocardium, has a very specific frequency under the MRI scanner, versus fat might have a different frequency. So when the proton is attached to different macromolecules, it gives off a frequency, and therefore such a condition will give off a specific address of the or unique feature, a physical property of the tissue. And by lining up this physical property of the frequency of these specific tissues, you can differentiate whether it is in pathologic state or normal state. And when you couple that in a three-dimensional spatial mapping, so-called a gradient system, then you can not only discern the physical property of the tissue, but also locate the position of the tissue. And by that, you can then generate three-dimensional or even four-dimensional maps. Four-dimensional, by that, what I mean is three-dimensional plus time. So you see examples of that. Now, what is the gradient three-dimensional space? It's basically just a set of coils that alters the gradient field of the heart from one end to another end. And when it performs so in three-dimensional sense, then you have a system that allows you to locate the specific point in space of the patient's body. So as I mentioned, MRI can get to any scan plane easily, and this is the example of that. We borrow a lot of the typical angles, nomenclature, typical cuts that you may be familiar with. We borrow these from echocardiography, such as the three-chamber view, such as the short-axis view, the two-chamber views. But MRI can also get into other less common views, such as the coronal or oblique views, depending on what structure you want to target. So this slide illustrates the common pulse sequence methods in a routine cardiac examination. So you can see heart function, perfusion. Viability is the way to look at myocardial scar, or this is also known as late enhancement imaging, or LGE, late gadolinium enhancement imaging, which you'll see a lot. There are also mapping techniques. So, for example, the common ones that I use are called T2 star to look at myocardial iron. T2 is a way to look at myocardial edema. I wouldn't worry so much about these because I'll come back to explain what they mean. But a typical exam, the point is that you can pick different types of pulse sequence to represent the question of interest. So as I mentioned, what are these, when you get an MRI report and you get back all these technical descriptions, what do they mean? I want us to spend a minute to explain sort of in general terms what they mean. Different types of MRI rely on sort of the fundamentally similar principles to look at different tissues. But for cardiac MRI, in general, T1 weighting means it is a way to look at signal enhancement. What sort of structures will enhance? Well, without contrast, in general, things that are very bright are so-called enhanced on T1 weighting. We're trying to look for tissue like fat or proteinaceous material in a effusion. It is also, because it's T1 weighting, it's actually used in all the cine imaging. So it's the primary technique to look at cardiac structure and function and scar. So most techniques, or 80 to 85% of all the methods that are used in cardiac MRI imaging are so-called T1 weighted. So most things are T1 weighted, that we use to look at structures, or whether the myocardium enhances secondary to use of gadolinium. Those are all T1 weighted. Perfusion is all T1 weighted. There are some specialized techniques that are more specific to look at a specific condition, such as T2 weighted. T2 weighted imaging of the heart is currently used to look at free fluid in the myocardium, or so-called myocardial edema, in the case of acute infarction, in the case of acute coronary syndrome or myocarditis. Then T2 weighted is to look at foci of tissue edema. T2 star is a completely different method. That is, it is T2 star mapping, actually, that is used to locate or quantify the amount of iron in the heart muscle. When you suspect a patient to have cardiotoxic effects from iron overload from various causes, then this is the method that one should use to quantify the amount of iron. So often a study is a combination of different of these techniques. There's also new techniques that are in the field. One of them is known as the T1 mapping. T1 mapping is fairly similar, but except seeing the T1 enhancement, it is actually quantifying the exact amount of enhancement. So weighting means you basically compare one structure to another. So it's just the relative terms. But when we actually look at mapping, you're actually quantifying the curve, the actual values of T1. That is a unique physical property of a tissue. And by quantifying that, you can then derive the amount of pathology or the severity of the pathology, such as fibrosis and so forth. So this is something that is increasingly used clinically, and most of the time is to look at edema, the amount of edema or fibrosis. As I mentioned, this is the T2 star. This is a typical picture that look at this as a patient with the T2 star that is normal. You can see the myocardium is not that dark. This is a series of 8 pictures. From the 8 pictures, you can then derive a decay curve. The shape of the decay curve is described by this constant T2 star. This is a patient with a normal, non-iron toxic myocardium. In contrary, you have a patient on the right side here where the movies, when it's played, the heart basically stay in a dark color, and it indicates that there's a high amount of iron toxicity, which is also seen in the liver. So this patient, these pictures are from the same patient. Both the myocardium and the liver are very dark, indicating that there's iron toxicity. The T2 star here is markedly shortened to 7 milliseconds. So a typical MRI study takes about 45 to 50 minutes, I would say. Some of them can be longer depending on if there are additional questions. It can also be shorter if you're not performing a stress test. This is a typical MRI scan with a stress component. So we do perform stress perfusion in patients with suspected coronary disease. And you can see this is a first pass perfusion. You can see there's circumferential perfusion defect in this patient who happened to have a hypertrophic cardiomyopathy. We'll also look at heart function. Then we can do perfusion at rest and couple that with the late enhancement method, which is the LGE, late gadolinium enhancement imaging, to look at SCAR. So you can then register their different segments of perfusion, function, and SCAR, and come up with the status of the myocardium, be it ischemic, or be it infarcted, or be it hibernating. You can then derive the status of the myocardium from in that sense. MRI has a strength because it has a wealth of information from the myocardium, as I mentioned. So in a way, I think it is complementary to looking to coronary luminal imaging techniques such as CT. For example, by assessing the amount of CT that is CT coronary stenosis, you can correlate how much myocardium is jeopardized and what the status of the myocardium. As I mentioned, whether it's ischemic or non-viable, and by that you can have a sort of a complete picture of what therapy should be best guided by this information. This is the so-called late enhancement technique that I want to get into now. This is a method that is, again, T1 weighted. It is aiming to bring out the scars, as in this case, at 9 o'clock, from 9 o'clock to 2 o'clock, you can see a layer of scar in the endocardium. This is a patient with a large myocardial infarction that is chronic. The outer part, the epicardial rim of the heart muscle is normal, is not infarcted. And it does so, this technique does so by, again, using some specific technique to bring out the contrast between the myocardium and the infarcted tissue. so-called inversion recovery to draw out the difference between these two structures, and taking the image in the quiescent part of the cardiac cycle and in mid-diastole, it will allow us to freeze the heart without blurring to generate this picture. Why is this type of technique, LGE technique, useful? Because it's been studied extensively against histologic infarction. It has a very good mapping correlation with the size and presence of infarction, but also the fact that it can be used to predict transmural extent, like the transmural extent of infarction, which is defined by the distance of A, the transmural distance of A over A plus B. And what that information is useful because it is a good predictor of how likely that segment of the heart will recover regional ventricular function or regional contractile function upon successful revascularization in patients with coronary stenosis. So it's a good predictor of whether heart muscle will contract again after revascularization. So it can be used as a guide to whether myocardium is viable or not, and planning of invasive procedures. Here's an example of a patient of mine who came to my office with complaint of shortness of breath and have some atypical EKG changes, just flip T waves throughout the anterior leads. And he never really had chest pain, and he also had a complaint of bilateral ankle swelling. So the picture certainly has some non-specificity in terms of coronary stenosis, but with this chest discomfort, I performed, and he cannot really perform exercise stress very well. So ended up performing an adenosine perfusion. You can see the stress perfusion. There's a dense perfusion defect from 6 o'clock to all the way to about 2 o'clock. Now the interesting thing is that this perfusion defect during stress, which represents ischemia, is overlying two foci of clinically unrecognized small infarction. One here at 6 o'clock, the other one at around 3 o'clock. But the point is that these infarctions are not in the same coronary territory, suggesting that this patient has multivessel disease with perfusion defect overlying two coronary territories, which is indeed exactly the case. He has two vessel disease, a occluded right coronary artery that gives off to a very dense perfusion defect, a very tight circumflex artery. The LAD was 50% narrow. So in a way, they had two significant vessels and ended up intervention percutaneously was not possible and ended up getting a bypass operation. This type of methods has been studied also for about almost 20 years now. Since its very beginning of getting into clinical medicine, perfusion by MRI is actually a very robust technique that can be used to risk stratify. This is a study that in my group performed a few years ago and published in Circulation. Basically, the point is that we can assess the patients with a pretest likelihood score, as in the clinical guideline, but we still, just by clinical assessment, still fail to risk stratify a good a proportion of patients, and these patients will benefit from non-invasive imaging, and cardiac MRI was able to risk stratify in the intermediate pretest likelihood. It can downgrade about 2/3 of patients to a very low risk if the MRI is negative for ischemia. And it can also increase the risk or put the patient's risk into a higher risk category if the MRI is abnormal and with positive ischemia in about a quarter of patients. So it is a useful risk stratifying technique in the different risk group. It's most effective being in the moderate risk group, as indicated here. So this slide illustrates the common clinical applications that we often receive from clinicians. These are the requests to perform cardiac MRI. These are all legitimate questions. I will show in the next slide which ones are more common. But again, this is a long list, fairly complicated. So the quick way to think about it is that if you have a question about cardiac structures and tissue components, then MRI is a very good test. And that's why MRI is actually a very good test to look at ischemia, viability, and etiology of cardiomyopathy. MRI is also a very good test to look at, to quantify the different degree of valvular dysfunction. And it's more robust in assessing regurgitant lesions than stenotic lesions. So stenosis, I think, are very well assessed by echocardiography. I think MRI, I don't think we can claim that MRI is better than echocardiography unless if the echo window is insufficient in some patients. But MRI is actually very robust in looking at aortic regurgitation, pulmonic regurgitation. MRI is also a very good test to look at pericardial changes and differentiating pericardial diseases against infiltrative conditions such as amyloid. So the list is as listed as below and so forth. The most common type of referral to cardiac MRIs are listed here. About a quarter are for the assessment of cardiomyopathy. MRI can not only assess whether it's ischemic or not, but also in the non-ischemic types, provide good amount of evidence of what type of non-ischemic changes does the patient have, such as infiltration or sarcoid or other non-ischemic types of causes that lead to cardiomyopathy. We also do about a quarter of our cases for planning of procedures, planning of EP procedures, most commonly planning of atrial fibrillation ablations, but also for planning of VT ablations as well. We also perform a lot of studies to assess for viability or assessing for myocardial ischemia and coronary disease, and then also other assessment of structural heart disease, such as for HCMs, ARVCs. Those are also common indications. Maybe easier to understand what MRI is not very good for and avoid ordering cardiac MRI for these purposes. Like echo, diastolic dysfunction as a condition is challenging. It has low dependency that many imaging continue to struggle with. MRI is no exception. Coronary MRI is inferior currently, except in very specialized centers in assessing coronary stenosis comparing to CT, cardiac CT. Guiding CRT in heart failure patients is still investigational. And often MRI is difficult in ruling out very small, the tissue content of very small structures like vegetations, especially when it's attached on a moving valve. MRI have difficulty telling whether it's a vegetation or a small clot when the structure is very small and moving. MRI also have some reduced diagnostic capability when the patient is in atrial fibrillation. So often when we're asked to rule out atrial clots in patients with atrial fibrillation, that MRI could be difficult. Now, if the atrial fibrillation is actually very regular, the MRI can do a very good job. So it all depends on whether the arrhythmia, the patient's arrhythmia during the scan is regular or not. Pulmonary MRI I think CT can do a better job at this point. So to rule out, to assess for the detection of PE is better by CT. I want to show some examples going from now on, just to illustrate some of the cases, to illustrate the strength of MR. This is the patient. This is a fairly old case. The left is a non-contrast scan. The right is a contrast scan. These pictures takes about 7 seconds to generate, so fairly quick. The patient wasn't even breath holding. So the reason I want to show the pre and post contrast is to illustrate the ability to look at tissue by simple methods. This is so-called the cine imaging, the SSFP imaging. So on the left side, you can see the myocardium, the left ventricle, the right ventricle. You can see that there's a massive area that is not contracting, a massive area of akinesis. It's an aneurysmal-like structure. There's also a structure that sticks out. It's highly abnormal. There's also a VSD that's going from the LV to the RV during systole. It's a very narrow VSD. You can see the size, the pattern of the jet that shoots all the way to the right ventricular free wall, indicating it's a sort of a very small, maybe even slit-like defect in the septum. After contrast, you can get more information. The myocardium enhances evenly, but whereas you can see a large aneurysm in this patient who had a myocardial infarction 2 months ago, now there's also an area that is akinetic. That is in the akinetic area, there's a region of black substance. This is a very large, multiple large clots form in the aneurysm after this large myocardial infarction. The patient also has a complication of the infarct, has a VSD as well. This is a case of a chest pain patient who presented to the MGH. A colleague of mine provided this example for me to show. This is the most basic, the right upper picture is a cine of this case. You can see that the left ventricle is contracting normally, except that there's a subtle wall motion abnormality here. Now, I would say, if without any other complementary imaging, it'll be hard to pick out this at 5 o'clock, this region that is hypocontractile. Although in retrospect, it's actually, I think I can appreciate it now. But the point is that you can use other techniques that cut the heart in the exact same imaging plane to bring out the tissue condition. So this is a patient with chest pain. You can see that there is when you perform the late enhancement, there's a foci, there's a focus of a scar. Is it a scar, or is it a chronic scar, or is it an acute scar? That's the question. This patient presented with several hours of chest pain without troponin elevation. So it could still be a infarction from a few days ago. So on first pass perfusion, there's a perfusion defect there suggesting that it is a hypoperfused myocardium. So now here you know that there's a hypocontractile region that is hypoperfused, that is also has a area infarction. But the T2 weighted image here really helps because it tells you differentiate whether it's an acute change or chronic changes, because chronic infarction will not have T2 signal, will not have edematous tissue signal. But in this case, this matching region shows brightness on T2 weighting, suggesting there's focal local edema. So indicate that this is a acute myocardial infarction with regional matching edema. So there's edema here indicating that there's an acute coronary syndrome. So the patient went to the cath lab and shown that there's an acute lesion in the circumflex artery. So by that, you can sort of lay out the different etiology underlying myocardial changes. Here's a case of a patient with admitted with symptoms of heart failure, and she was very sensitive to fluid when people gave her fluid, but at the same time, she was also intermittently hypotensive. So an echo showed that she has what was described to be left ventricular hypertrophy, global dysfunction. But that's sort of fairly non-specific, right? Because she has, clinically, diseases such as hypertensive heart disease or coronary artery disease can also look like this. You can see that there is a bilateral atrial enlargement. The right ventricle appears to be contractile, but maybe mildly dysfunctional. The LV is, the wall thickness appears to be increased. But when you actually give contrast, then it gives a lot of clues. This is a patient with cardiac amyloidosis. You can see that there's diffuse, non-infarction-like infiltration of signal here, of late enhancement here. So you can see the atrium is markedly infiltrated. There's these patterns that are sparing the endocardium, but hitting the epicardium as well, hitting the epicardium. These are not infarction type. The blood pool is darker because of the high amount of contrast accumulated in the myocardium and their so-called inversion pulse. So all that feature with the biatrial enlargement, with the diffuse infiltrated pattern that follow the base more than the apex, this is a case of amyloidosis that we see often. And these sort of patterns are so specific often. In clinical cases, they're so specific that they can avoid the need for the patient to need to have a biopsy. Here's a case of a patient who had a family member with sudden death, and the patient himself had ventricular tachycardia. The patient has not gone through genotyping at the time. You can see that he has a foci of thickened basal RV with akinesis here, and there's a hinge point right there. It's very abnormal. The RV is mildly enlarged. On the fat imaging, you can see that there's this matching area of brightness, which is indicative of fat in the epicardial part of the myocardium. Again, matching the region that is akinetic. So this fulfills the current task force criteria of ARVC. In addition to some of the other clinical factors. So MRI is not the sole criteria. You have to look at other concurrent conditions as well by the task force criteria. So this is a interesting ARVC uncommon case. But what is actually more common is that we now have noticed that ARVC is certainly not a disease that is restricted to the right ventricle, but also is, we see a lot of many patients with ventricular tachycardia, and then because of the ability to see fatty infiltration and scar formation in other parts of the heart, you can see that there's this patient has fatty infiltration of the myocardium here in the left ventricle, which is suppressed by a fat suppression pulse. So bright strip here is fat that can be verified to be fat by us when we're during the scan putting a fat suppression pulse to suppress the signal. So you know with good degree of confidence this is a strip of myocardium that is a fat infiltration. And these sort of cases have been described across different centers, that fatty infiltration leading to ventricular arrhythmias is not a condition that is restricted to the right ventricle. Here's a patient who returned from a business trip and experienced shortness of breath, and the echo that was performed showed a VSD. So the EKG did not show anything that is too spectacular, that is too revealing in his diagnosis, but the MRI does offer some additional information here. So you can see on the cine imaging, you can see that there's a VSD here. This is the septum, this is the inferior wall, and the septum here. But the most interestingly, the VSD here, you can see the hole here, the septal defect here, but the surrounding myocardium is markedly thinned out. It looks like there is a replacement fibrosis. Now, when we actually perform late enhancement, you can see the thin out myocardium is actually a piece of scar. So this is a patient with a recent unrecognized myocardial infarction that has completed his course of infarction, myocardium thins out, and he suffered the consequence of a ventricular septal defect without him to be clinically recognized, and it was only found later. So when he was asked again, he reported actually during a trip during his business trip, he had episodes of chest discomfort that he did not tell anyone or sought medical help. And it's fortunate that he presented now and at least be recognized and treated. This is the patient who I won't tell you more information before I show you the picture. He presented with sudden onset of chest pain and pre-syncopal spell and arrived to the ED with a markedly elevated troponin. You can see the EKG is very abnormal. There's diffuse ST elevation here in lead AVL, AVR, lead 1, V1 to V3. So also there's ST depressions in the inferior leads as well. So, it's a little puzzling whether this is actually a acute infarction or other causes as well. Certainly with the extremely high troponin is very concerning. So this is the picture. Now what turns out is this is really a 19-year-old college student who presented with acute chest pain. So clinically, the suspicion for myocarditis was always there. One also has to entertain the possibility that could it be some kind of coronary spasm that led to infarction and elevated troponin. But I think the overall clinical picture was leaning towards myocarditis. The MRI in this case verify it, and actually not only verify it, but also give some clues about the subtypes of myocarditis. So on the left panels are when he first get admitted to the hospital within a day or two. This MRI, by resting assessment of the myocardium, you can see that there's tremendous amount of late gadolinium enhancement in the epicardium of the lateral wall. It spares the inside, so this is clearly not an infarction, but a markedly large area of acute inflammation and some scarring. The acute inflammation is matched by the bottom picture, the T2 weighted picture, that show there's extensive T2 edematous tissue. And you can see how thick the myocardium is, indicating that the whole heart is inflamed, but most specifically in the lateral wall, the epicardial part. Now, this sort of changes is classic of viral myocarditis, and many have implicated this lateral wall involvement to be associated with certain types of viral etiology, like as B19 or parvovirus, which is exactly what he turned out to be. The virology, of course, is not available until many weeks later. About 6 months later, after verifying on MRI that he has a myocarditis, he returned after a course of just supportive treatments. He wasn't given any steroids or anything like that. So, you can still see that he still has a small residual scar. Although the edematous, the inflammatory region, is by and large resolved. His left ventricle went from 30% to back up to 50%, which was also predicted by MRI that there's a lot of edema, so likely the LV function would improve, which is indeed the case. This is a patient with a very thick, a different reason to have a very thick left ventricle, as you can see here, markedly thickened septum, and especially anterior septum, anterior wall. And this thickest region is matched by late enhancement of heterogeneous signal intensity. Many of you are probably already telling the diagnosis that I'm trying to say. This is a hypertrophic cardiomyopathy. Patients who often affect the anterior wall and anterior septum markedly, with about 30 to 40% of these patients will have late enhancement affecting the most hypertrophy segments of the heart. This is a different case of a patient who presented with also ventricular tachycardia. There's multifoci involvement of the LV by late enhancement. It involves the septum. The signal intensity is extremely bright. you can see multifoci here. So this is a case of the fact that it involves the septum is very bright and it multifoci makes us think of a infiltrative condition. You can see that the inside, the endocardium is spare, so it's not an infarction. So this is an infiltrative condition that is strongly suspicious of cardiac sarcoidosis. And indeed, the myocardial biopsy confirmed the diagnosis. Here's a case of a patient with pericardial disease. There are two different versions of it. This is on the right upper panel, there's a patient with acute lupus flare. You can see a large pericardial effusion that is fairly bright on T1 enhancement, T1 weighted imaging, so suggestive as an exudate. The heart is sort of surrounded by this large effusion. But in patients that are of a different variety of pericardial disease, such as in this case, a more chronic scenario, a patient with recurrent pericarditis and eventually led to constrictions, you can see the pericardium, as illustrated by the dark band here, is markedly thickened. This dark band, what we call pericardial apparatus, which contains not only the pericardium, not only the thickened pericardium, but also the pericardial space that contain pericardial fluid as well. As you can see on the left side, this dark area is the pericardial apparatus. It contains the two layers of pericardium and the space in between. In this case, it's markedly thickened. The heart looks constricted and sort of have a matted down appearance. So it appears to have been matted down to the adjacent fat. This is the epicardial fat. You can see the coronary arteries here, but you can see that the structure appears to be stuck. So it gives you that the LV is sort of stuck inside a thick layer of pericardial sac, a thick pericardial sac. So that's the chronic, but if you give contrast, you can actually get more information. You can see that in this case, the pericardium is markedly enhanced, meaning that they are fibrotic or has ongoing inflammation. You can see the two layers of pericardium. And in between, there's basically non-mobile fluid, or also even some debris materials or fibrinoid materials in the pericardial space. So this is the case of a classic case of chronic constrictive pericarditis. Now, to call constriction is often you need to look for other information as well. So you have to look for consequences of constriction, such as the shape of the heart, the dilated atrium, the size of the SVC and IVC, the shape of the RV. Those are all criteria that we should look separately for pericardial constrictions. But these are just examples of a chronic case, chronic pericardial disease, and acute pericardial disease that we see clinically. This is again another case of chronic changes that is without the effusion. Primarily, you can see the dark band in black blood imaging. You can see the dark band of pericardium here. But when you actually give contrast, the dark band is matching an area, the pericardium that enhances very vividly, which is indicative that the pericardium is markedly fibrotic. So you can see it on the short axis view here. After contrast, the pericardium is markedly bright. I want to finish off in the next few minutes by some of the contraindications for MRI scan that you should be concerned about. There's a condition known as nephrogenic systemic fibrosis, or NSF, that many of you may already be familiar about. It is associated with gadolinium administration. It is specifically related to patients or describing patients with severe underlying renal dysfunction. And it was reported since 1997, and in the subsequent 10 years, there were over 200 cases that has been reported worldwide. The incidence of reporting is probably more than that, given that it's retrospectively identified. it is reported that it is most at risk. It is primarily those patients with severe renal dysfunction, with an eGFR of less than 30, that is at risk. The risk, though, is not very high. It's still, in those patients, even if they're exposed to gadolinium, the risk is about 0.5%. Now, since 2006 and 2007, most hospitals in the US, if not internationally, have been performing screening using using eGFR for any patients with these conditions. The list may expand to other groups, such as patients who are taking non-steroidal anti-inflammatory drugs, hypertensive patients, and a routine eGFR screen within 30 days before any MRI performance that require gadolinium. And since then, the new incidence of NSF in the United States is exceedingly low. In fact, is considered to be reportable since the implementation of screening. So, but it indicates the importance of screening that is applied in most, I would say in most, if not all, MRI programs. Now, other situations that you should consider to be somewhat cautious, and at least be somewhat cautious about performing cardiac MRI, is the presence of pacemaker and ICD. It is still considered to, many models are still considered to be absolute contraindication MRI in inexperienced centers. But although there are many reports that these so-called legacy pacemakers are safe. Now, what does it mean by legacy pacemakers? There are now many different models of MRI conditional pacemakers. That means MRI can be performed as long as the scanning procedures is following certain conditions. Those MRIs are specially made to be safe, to be conditionally safe inside the scanner. Now, I'm not talking about that. I'm talking about the models that are currently in clinical use that are not the MRI conditionals. Those are so-called legacy pacemakers. And FDA requires that there are very specific criteria of imaging any pacemakers. I won't go into the detail here, but just to say that there are several models of pacemakers, and one model, one or at least one, I think there are probably several now, of ICDs that are approved for MRI imaging at 1.5T to be done. But also there are increasingly common that centers are performing MRIs on the legacy devices because of there are several large registry studies that show that as long as you're safe and you follow very strict criteria with monitoring, performing of the MRI on these devices won't damage the device, and also do not cause patient harm. So something to be aware of. So with that, I'd like to close with two questions from the materials we have discussed. Which may be a contraindication to cardiac MRI scanning? Coronary stenting, a stent placed within 24 hours in a patient who presented with ACS, or presence of sternal wires placed from a bypass surgery, breast cancer patients after a mastectomy, a patient with a SureScan permanent pacemaker, a patient with an Evra ICD device implanted, or a patient with known renal insufficiencies and eGFR of 40. Which one of these may be, or at least is the most risky to perform a cardiac MRI? Now, some of these materials I have not covered, so but we can use it we can still discuss this. So the answer is C. Breast cancer patients after mastectomy. The reason is that the other conditions are actually pretty considered to be acceptable. Choices D and E, are MRI conditional devices. Choice F, eGFR 40, is actually, with the new generation of contrast agent, is actually very safe to perform MRI with the dosage that is required to perform the MRI. Sternal wires is actually not a risk because it does not cause local heating, or it does not or does not cause significant local heating, and it does not move. So it poses no risk to the patient. Coronary stents is actually very safe. Right after its placement, most programs are considered to be safe to undergo, and also the current guideline for the MRI to happen pretty much right away after the stents are placed. But it's the breast tissue that often a concern, because after mastectomy, if the patient has breast tissue expander, the expander is directly in contact with breast tissue, and it can act like a electrical coil, and it can heat up and can potentially cause damage to the local tissue. So that's a absolute contraindications to MRI imaging. So I list the reference here for your review. Another question: which clinical indication is cardiac MRI least helpful? So these are going into the clinical applications now. A 60-year-old man with new onset cardiomyopathy. B, a 35-year-old IV drug users with fever and a 5 millimeter mass on a tricuspid valve. C, a 50-year-old female in atrial fibrillation with suspected pericardial constriction. And D, a 60-year-old man with chronic total LAD occlusion with a question of being asked is whether the myocardium is viable, whether he should be a candidate for bypass surgery. And E, a 60-year-old man with fatigue, low voltage on EKG, and increased LV wall thickness. So the answer of this is B, and I'll try to go into that. So what are these scenarios trying to ask for, right? One, A is really a nuanced cardiomyopathy. MRI can really answer the question very well, whether it's CAD or not, whether if it's not CAD related, whether it's infiltration or types of non-ischemic cardiomyopathy, MRI is very useful. C is a typical case for pericardial constriction. MRI can look at the anatomy of the pericardium and enhancement and whether there's any constrictive physiology fairly well and differentiate constriction from infiltrative cardiomyopathy. So C is not the answer. D is a typical case of a patient before bypass. The patient may have other coexisting comorbid conditions, making the surgeons feel uncomfortable taking them to the OR. In that case, viability assessment in the LAD territory was called for, which is also a reasonable request. E is really a patient with suspected amyloidosis, low voltage, fatigue, increased LV wall thickness. The MRI can also, as I mentioned, is a technique that can show very specific pattern in infiltrative conditions. So it's very useful to diagnose or exclude cardiac amyloidosis. B is the answer because it is the most challenging for cardiac MRI because it involves a very small structure that is fibrillating on the tricuspid valve from cardiac motion. And as I mentioned in one of the slides, this is a patient that will often have trouble telling whether it could be a vegetation, it could be a clot, or even seeing the structure altogether. 5 millimeter is fairly small. In general, anything less than 7 or 8 millimeter, when it fibrillates, we may not be able to see it from the surrounding blood signal. So B is the answer that is the least likely to benefit from a cardiac MRI. I've listed a reference there for a current practice guideline of cardiac MRI for your review. Hopefully you find it useful.